A brief review of the technical aspects for the basis of harvesting, purification, and placement of fatty tissue will be presented, along with the scientific and anecdotal evidence for using this specific technique. The surgical technique involves the harvesting of small intact parcels of fatty tissue with a syringe and a blunt 3mm cannula. Dr. Coleman focuses on the effect of centrifugation on harvested fat, studies the growth factors and primitive cells residing in different densities of grafted fat, the use of smaller bore cannulas for facial fat grafting, particularly in the periorbital region, and new studies on injection techniques.
My disclaimers are I get royalties for instruments sold by Mentor. I'm a paid consultant for the Armed Forces Institute of Regenerative Medicine. The U.S. military is actually very interested in fat grafting now, and especially the stem cell applications. And I'm also a paid consultant for Mentor and Musculoskeletal Foundation. And I receive royalties for my books. So, and I've been doing this for 27 years now, the fat transfer. And so I tried to put together a lot of my experiences for you today. But one of the interesting things is while I was in Milan in Riccardo Mazzola's library, we found that fat injection had been described as early as 1908. And luckily in German, the word for fat atrophy is fat atrophy, and for fat injection is fat injection. So I was able to find it on my own even. And this is the first description or photograph of a result from fat grafting from fat atrophy, a lot like this type of patient that we see with hemifacial atrophy. I had some really good experiences initially, as I told you yesterday, with fat grafting to the body, and that sort of propelled me along. But one of the things that really happened, even with these earliest patients, is noticing the change in the quality of skin. And I think that is as important to a contribution as filling for fat grafting. And in that same book in 1912, Eugene Hollander talked about infiltrating scars with fat grafting, and specifically gave a picture of a breast that had fat infiltrated into the scar of the breast. So we've been doing this a long time. Plastic surgeons have been injecting into the breast and scars for over 100 years, and they've been writing about it for a long time. The use of fat grafting for treating intestinal perforations and uterine perforations and liver tears, and even repairing bladders, and especially in orthopedic applications. The number of descriptions from the 20s of orthopedic applications are really remarkable, and we're now beginning to discover that with things like Dupuytren's. So the reparative and regenerative aspects of fat grafting have been recognized for much more than a century. And the first person who really talked about the details of fat grafting by injection was Charles Conrad Miller in 1926. He wrote a book on implantation through cannulas, and he described a powerful screw piston syringe and that he was able to inject subcutaneously into depressions. But he went much further than that. He also described the correction of facial scars in 36 cases with only moderate shrinkage of the fat, and reported 2 cases of fistulas, which defied all other methods of treatment which he was able to cure with fat, and he followed for a long time with no repeat. In my practice, this patient was one of the really pivotal patients. If you've ever heard me speak before, you've probably seen this, but she came into my office 2 years after I put 1 milliliter of fat down the center of her nose to improve her light reflex there, and she asked what happened to her childhood scar. And it made me realize that there was something going on with fat grafting that was more than expanding. There was a remodeling and repair of this area, which I think is really remarkable. And then other patients came in later on and said that they noticed that the hair had been restored to their bearded areas, especially in the acne-scarred areas. And this really emphasizes that fat grafts repair scarred skin to a healthier condition. Sometimes it completely gets rid of the scar. More often, it really decreases it. Like this patient, if you look on the left side of her face, she had significant acne scars and also had a deformity of her lip from the Gore-Tex, which had been placed. I took out the Gore-Tex and filled in the scars, and some of the scars disappeared completely. And this is her 3 years and 8 months after one fat grafting procedure. And this patient was a real curiosity to me. He came in with this biceps tear. This is his biceps. And I placed fat, and this is 26 months after the last infiltration. And the thing that's remarkable is he came back, and he is obviously a bodybuilder, and he said that his biceps curl had returned to almost normal after the fat injection. So he'd had a significant loss in strength after the biceps tear, and he regained strength. And now, this is another biceps tear that I treated that said he had a similar experience. He wasn't a professional bodybuilder, but that he had a regaining of strength. And then I got his right biceps looking so good that he ended up doing his left biceps just to catch up with the right. So, and now, what is the future of surgery? We're moving now toward preventive treatments, minimal or non-invasive therapies, and the new buzzword is regeneration. Now, regeneration meaning the healing or treating of your body with itself, rather than using drugs or invasive procedures. And it's really not just in surgery, but in all of medicine that we've been looking for that. And the first holy grail were embryonic stem cells. Unfortunately, we weren't able, after trillions of dollars of research, to really tame them and use them the way that we were hoping to. But in the process of doing all that, we started using bone marrow-derived stem cells, and really having some success with that. The problem with bone marrow is that you have to aspirate it, and then you have to grow it. And a lot of things can happen in that process, whereas fat is really much more easily accessible. And this paper came out in 2001 from the group in Pittsburgh, and basically it described that there was human lipoaspirate, which contained multipotent cells, which may give us an alternative stem cell source to bone marrow-derived stem cells. And the important thing about this paper is that 4 of the authors were plastic surgeons. So we were really there for the first recognition of the value of the stem cells that are present in fat. And right now we know that human adipose tissue has the highest percentage of adult stem cells of any tissue in the body. And if you talk to Gino Rigotti, he'll tell you that there are only 5,000 stem cells per milliliter of fat. And if you talk to Saitori, they'll tell you that there's 10 or 20,000. And then from the Germans started saying that there were as many as 350,000. But then the Japanese said it's more than 1 million. And so that really human adipose tissue is chock full of stem cells. And this article came out by Kotaro Yoshimura, who you're going to hear a lot about today from me. And basically, the article says that adipocytes account for only 16% of adipose tissue. And I think that's really a shocking thing to say. And he studied them every way you could right now, using histology and G6PD, or G3PD, flow cytometry, and adherent cell culture, actually growing the cells too to see what stem cells there were. And he came up with the conclusion that 16% of the cellular content was adipocytes, and 30% were adipose-derived stromal cells. So that's more. That's almost twice as much. of the stromal cells as there are adipocytes, and then endothelial cells are 15, blood-derived cells, not including the blood itself, is 9%, and then others 30%. But I think that's really a really important, exciting bit of knowledge that I'm going to tie in later on again. But I'm going to just take a break now and talk about the technical aspects of fat grafting. And these are the big questions, and I think these are not as important as the next one, which is the placement. But I'm just going to tell you the technique that I use, just basically for harvesting and refinement. And this is actually in the book in excruciating detail. Bill brought up the donor site, and it turns out that there are some articles that sort of lead us to believe that the abdomen and inner thigh at least have more stem cells in them. And so we're looking for getting as many stem cells as we can into the fat. So the abdomen and inner thigh are not only the most convenient place to take fat from, but also they appear to have more stem cells in them. So those are the sources that I go to first, although I use every place in the body. Now, the method of harvesting that I use is syringe harvesting. I think it really provides a lot of control, and especially for the face, I think it's an important thing to do. I think in the body, I still use it, but there may be alternatives. I use these harvesting cannulas, 15 and 23 centimeters. I think a curved cannula is very useful because it lets you sort of work around, hug around the body and not gouge out the area, and let you remove superficially, like from the upper midline. And I use, when I'm doing general, 0.2% lidocaine with 1 to 400,000 epinephrine, and I put in a volume of 1 to 1. I don't 2-mess. I use 0.5% with 1 to 200,000 when I do a local case, and I've just avoided doing super wet techniques. I think it disrupts the niche, and it becomes time-consuming and inefficient compared to regular syringe harvesting. I use a Lamis infiltrator or just a 10 cc syringe and change it to infiltrate fluid, and then I use the harvesting cannula with my hand only. And really, I use oil to lubricate the incision sites, and the technique for removal is really trying to minimize mechanical trauma, really gently pulling back on the plunger, 1 to 2.5 milliliters, and really trying to minimize the pressure of vaporization, which is the negative pressure that boils water at room temperature. I take the 10 cc syringe after it's harvested and remove the plunger from the end of the syringe and place it into a centrifuge at 1286 Gs for 3 minutes. And now you ask, why centrifuge? Well, obviously it's to separate and get rid of the oil. You don't want to reintroduce that. Really get rid of the aqueous elements, which is the most dense, and remove any potentially harmful substances. And I'm going to explain what Bill mentioned, and that is the importance of high-density centrifuge fat, which really appears to survive to a greater extent than low-density. It has a lot more stem cells in it and a lot more growth factors. And there's the potential for the less scarring after implantation also. I decant the oil layer. Don't remove the lure lock before pouring it off, or you'll pour the whole thing into the beaker. Then I remove the cap and allow the fluid component to drain. And I use wicks to make sure I get as much oil out as I possibly can. And then place the fat into 1 cc syringes. Now, and then replace the plunger. So here's a video of my assistant placing the fat into a centrifuge right after it's been harvested. She's putting a balance in, one of them. And then she closes the lid and centrifuges for 2 to 3 minutes. I've always said 3 minutes, and I found out recently I've been doing it for 2 minutes for a long time, and my staff forgot to tell me that they had reduced the time. So anyway, pour off the oil and let the aqueous portion drain out. If it needs some help, you can use your index finger to push it through. Again, pour off the oil and then let the aqueous portion drain out. And then you can see they're sitting there with the wicks in place. And then it's remove the wicks and just let the column of fat slip back and inject it into the 1 cc syringes. Now, the first 1 cc syringe is the most dense fat. It's the fat which was at the most inferior part of the centrifuge fat. So that's, when I'm talking about high-density fat, it's usually, the way that I harvest fat, I usually get 5 to 6 milliliters per 10 cc's. And so it's the first 2 milliliters of the 5 or 6 cc's that I'm calling high-density fat. So, and then eventually you get to the very end, which is about 5 cc's up, and that's the low density. I think that the donor site harvesting and processing, there's so many ways to do it, and they work. I think that we still have a long way to go before we know which way is the right way. But for placement, I think there's only one way, and I think almost everyone agrees with me. From a presentation I made in 1996, there's this drawing of a glob of fat that's been squirted in to the area, and I'm going to talk about the levels a lot in just a few minutes. I think it's the most important part of this talk. But you want as much of the fat parcel as you possibly can get close to a blood supply. Otherwise, you're going to have scarring, fat cyst. And the thing to remember also is that just because the surface of the skin looks flat at the end of the case, if you didn't put it in evenly, if you put it in irregularly and then you manage to mush it around so it looks smooth, it may die very unevenly. So you really want to try to get the fat in as evenly as you can, not just so it looks good, so it actually is evenly placed. This is what happens if you don't. And this was done by a very important plastic surgeon who I knew very well, and he put in way too much fat, and then decided to get rid of it with Kenalog, and ended up with atrophic skin over way too much fat and placed it regularly. This is a European surgeon who did this, who also is extremely well known, who just placed the fat in a really unhealthy fashion. And this young lady, I'm going to go through at the end of my talk and show you a video of her. But the goal is really to place the fat evenly, and to improve the quality of the skin as much as possible. And so, like for her, for instance, you can see it's very evenly placed right up to her infraciliary mound and all the way to her nose, giving a nice change in the quality of skin and the texture of the skin. And I'm going to go through her in more detail in just a little bit. But this patient, you can see I just put like 1.5 cc's in the upper eyelid and about 4 cc's in the lower lid, and you get not only a really nice fullness of the lower eyelids, but really look at the quality of the skin, the pores, the wrinkles in these patients. But you can see the quality of her skin in this area, and even the pore size has tumors really diminish considerably. They don't go away, obviously. And I like to leave a little floppiness at the bottom of a upper eyelid, but this is just a nice gentle filling evenly of that area. And even for a patient with a little rougher skin, you can see a really nice improvement in the quality of the skin, the size of the pores, the color of the skin, really making the skin more youthful. Now, one of the things that I did was on my studies is I actually provided the lipoaspirate, and this was one of the latest studies that we published. We did it first; it didn't get published until later. But this really looking at the graded lipoaspirate, just whether there was an optimal layer. So when you centrifuge fat, you get the upper layer with oil and the lowest level with blood, water, and lidocaine. And then what I'm going to be talking about is this level right here, the lowest level, comparing it to the upper fat layer, which we're going to call this high density and this one low density. And what we found out in our studies was that high density had twice as many stem cells as low density. And you know, one of the really important things that we need to constantly remind ourselves of is that when we move fat, something has to tell it to survive. It just doesn't go there and grow on its own. And so I think growth factors are an important element of what we do. And really looking at the transplantation of growth factors is important. And this is a study from Germany again, from Norbert Palua, who really looked at the oil and the aqueous portion and the pellet and saw very little growth factor. All the growth factor is really focused in the centrifuge fat against the fat itself in the middle, and not going to the aqueous or the oil portion. And likewise, when we look at the high density and compare it to the low density fat, it has many more growth factors than the low density fat does. And that was an earlier article that we described this model of fat grafting, and we used it in order to study the high density and the low density fat in vivo. So we used adult non-immunocompromised mice, and we harvested it at 2 and 10 weeks, and what we found is this diffusely infiltrated fat. And I want to emphasize that it's not a glob of fat. It's one of the big problems with almost all the studies that you look at is people are squirting in globs of fat in their experiment, but that's not what we do when we're operating. So we really need to infiltrate diffusely. And what we found is that the high density fat had more CD31, which demonstrates more vascularity, and the high density had much greater vascularity at 2 weeks and 10 weeks than the low density. And just looking at it grossly, the high density was much more persistent than the low density, and the low density had a lot of oil in it, which makes us worry about injecting low density fat into breast. So I think this portion right down here, and I encourage you to look at the article, but this portion down here is really valuable. And so the upper fat layer, the low density, has less vascularity, less persistent, and oil cysts, and the high density has increased stem cell counts and growth factors, more angiogenesis, and better persistence of fat. Now, this lady really is the person that showed me another factor about fat grafting that I think is really exciting, and that is that it gets better as time goes on as far as the influence of the tissues around it. This lady came back at 4 months, and she was looking very good. I just put 4 cc's of fat into each temple, and you could see an improvement. And then she came back at a year, and it was much better. So at 4 months, it was good, but actually, if you look at the veins in this area, you can see that they're significantly diminished between 4 months and a year. So let's really blow that up so we can see it clearly. But you can see the vein, and what's happening here, it appears that the skin is thicker, because it's very hard, if you try, it's very hard to get between this vein and the skin. So most of what's happening here is thickening of the skin, maybe I got a little bit of fat between the skin and the vein, but what happens from here to here is the remarkable part, in that it continued to improve, and the vein almost disappeared, which doesn't always happen, but in this particular patient impressed me a great deal. It made me aware that something was happening. And I think one of the big things about fat grafting is its influence on the increase of collagen in the skin. And this study from Lyon demonstrated that skin over grafted fat was almost twice as thick as control. So it appears that the fat tissue is actually increasing the dermal thickness through induction of new collagen synthesis. So it's much more than, and this is a whole new regenerative aspect of fat grafting. And here in a reconstruction case in which this patient with these hemangiomas, I placed fat all over her arm, and you can see at 3 months, it still was pretty dark, and when she came back at 2 years, the skin had thickened so much that you really had a remarkable change in the color, as well as obviously the contour of the area, but I think mainly through the thickening of the skin. So let me just talk about the technique that I use. I think it's really important, and that is moving through the tissues with a blunt cannula, really following the natural tissue planes, not cutting a pathway, but pushing a pathway through the natural tissue planes. Then as the cannula retreats, the host tissue falls back into its natural condition with the fat there, and with the fat in little parcels close to capillaries. As you're going along, this really encourages stability, and you can place quite a bit, but you need to always think about, am I getting the fat next to a capillary? And from South America, a study a long time ago talked about the fact that you could only be about 1.5 millimeters from the surface, from the contact with capillaries, and actually even at that level, they demonstrated 60% loss of fat grafting. They estimated that really a 60% loss of fat grafting at 1.5 millimeters. Now the newer information is very different than that, and all the information you're about to hear is from Kotaro Yoshimura's articles, and so his picture will be on all the pages that I sort of borrowed from him. But basically, there is a surviving layer of fat, there's a regenerating layer of fat, and there's a necrotizing layer of cells, not of fat. So for a parcel of fat, those are the zones. And the periphery is very small. It's only 100 to 300 microns. But in that little section there, the adipocytes actually all survive, usually. And the stem cells survive also. And then there's another level, the orange level here, which is intermediate, and it's 600 to 1200 microns. And the adipocytes all die in that. All the fat dies. And the stem cells live. So you have death of all the adipocytes, 0.1 to 0.3 millimeters from the edge of the fat parcel. So, and then this zone, though, in which the adipocytes all die, the macrophages phagocytize the dead adipocytes, and then the stem cells grow back to provide the volume. So the volume is not coming from adipocytes surviving, but from the adipose-derived stem cells growing new fat cells. And he actually followed it for a time period, and the number of new small adipocytes that were being created increased rapidly after grafting, and peaked at about 4 weeks. So at about a month, he saw the peak and declined to baseline at 12 weeks. So basically, the stem cells are growing for up until here, and then gradually going down and being stable at about 12 weeks. So 12 weeks is about the end result, which is what I've basically always said was my clinical experience, that things seem to stabilize around 3 to 4 months. And so what happens in the very center part, which is the necrotizing zone? This is 700 to 1.5 microns from the edge, and the adipocytes all die, and the stem cells all die. So nothing lives past 700 to 1500, depending upon the circumstance. And what happens to those dead cells? Well, the stem cells die, the adipocytes die, and there's hopefully phagocytosis, maybe some fibrosis and calcification. And that's for a minimal amount of cell death. If you get a lot of necrosis, if you get a big glob of fat in there, the stem cells die, the adipocytes die, and there's massive cell death. And you get oil cysts, fibrosis, and cyst wall formation, which can happen very easily. And this is a really, really important reason to put your fat in small parcels and mini passes. Now, therapeutic radiation is a real boon to us, but it can cure a lot of illnesses, but it also creates a lot of problems. And this is a patient who had a failed craniotomy revision, and came to me because no one wanted to reoperate on her. And I put 9 cc's into her temple, and you can see a nice improvement of this irradiated area with fat grafting 26 months after 1 fat grafting. So, and she felt like she had an increase in hair growth, which has been mentioned a lot of times by people who do this type of surgery a lot. So therapeutic radiation can create this type of problem, and usually the damage is progressive and unrelenting, and free tissue transfers has been the mainstay of treatment in the past. This is a favorite patient of mine who was a radiation injury problem. When he was 8 years old, he had a rhabdomyosarcoma of the masseter, which was treated with local radical excision and radiation, and left him with a real big deficit of the jawline, really sclerotic, scarred down, difficult to move. And the first session, I put 115 cc's. I would probably not put that much now, and I put quite a bit of that into the mastoid. And you can see the change in the shape is really dramatic, especially of the ear. And I was able to get a significant improvement in size and a really big change in the quality of his skin, and even an improvement in his beard. And that 115 cc's felt completely natural. Yeah, I did 2 more sessions and was able to take him to this point with really soft, pliable skin. So it really felt natural, like skin, muscle, and fat. And I think this is a really exciting advance. And Gino Rigotti actually has written about this extensively. He wrote, beginning in 2005, he started presenting this type of patient in which he completely cured almost every patient that had radiation injury with fat grafting, and even really horrible radiation damage like this. And so I went to the laboratory to try and figure out what was happening with these, again using the Coleman technique and the model that I described to you before. What we found out is that by putting fat under the skin, really after in irradiated tissue, that the alopecia improved, the skin color and texture became more normal, and the ulceration significantly healed. And really what we could see is that, and I think this is really important for fat grafting, is it improved the vascularity and decreased the scarring. And we did the same thing. We did the same study for burns, and the conclusion that we made there was that the clinical improvement in full thickness burns after fat grafting showed an improvement in color, the skin texture was more normal, and dramatically increased the healing at 4 weeks to 8 weeks, and that was probably the most important. So basically what we're seeing in thermal injuries as well as radiation injury is accelerated early revascularization. So the fat is bringing in a blood supply, it's decreasing the scarring, and improving the scar quality. So, and one of the reasons that that's important is it probably is how fat grafting is working any place you put it. So really, for when we're trying to reverse aging and sun damage in the face and hands and any place, probably those factors are playing in too. And I think this is really important that this high density fraction is probably the regenerative portion. It probably is somehow the other compressing the cells and letting the larger cells go to the top. So it's really improving the stem cell activity and reducing scarring, oil, calcification after implantation, and really concentrating the growth factors. So I think that this regenerative zone is going to be the important thing that we have to figure out to decrease the variable results that you get, and to really maximize the outer and the middle zone and avoid the necrotic zone. And so I think growth factors and maybe stromal vascular fraction may be working that way to improve the regeneration portion. But if we already have so many stromal cells present, there's a real question. If 30% of the adipose tissue is stromal cells, then do we really need more cells? So we need to really look at that and think about whether cell-assisted transfer even makes sense. And again, the takeaway here, the really important thing, is that an improved blood supply is created by fat grafting and a decreased scarring. And also there's a lot of evidence that it decreases inflammation and maybe even has an antimicrobial effect. So in closing, I'm going to show you this patient. Really, again, the goal is a long-lasting enhancement. And in her, these are the amounts that I placed, just 0.8 into the upper eyelid and into the teardrop 1 and 0.7 cc's. I use a blunt cannula when I'm going deep, and I use and that's really, especially if I'm near a nerve or an artery that I'm worried about the infraorbital foramen, I always use the most blunt cannula, but I more often use the flatter cannula, which people have been mentioning, and Bill in particular, but this sort of spatulated cannula, especially when placing in the lower eyelid and the lip. And have been using for some time now much smaller bore cannula, and I find that it really does enhance the procedure. So this is my operating room. Again, you can see there's the screen in the back, and I'm putting local. I put local in the incision sites, and I sometimes use needles, and sometimes I use 11 blade to make the incision sites. I place the local anesthesia with the same cannula that I use to place the fat. And you can see here I'm going in the lower eyelid against the tear trough. So I'm going perpendicular so far to the tear trough. I think that's very important. And then I'm going to feather. I'm not going to stay in any one spot. I'm going to go up against the eyelashes, and then I'm going to feather the feather down a little closer to the nose, but constantly moving here. There's not a lot of space, and at least in my imagination, I want to have every column of fat that I'm placing in a different location than the last one. And you can see that it's taking me a long time to place 1 milliliter of fat. Like Bill showed, you really need to place probably 1/50th of a milliliter per pass or less in the eye to get a good result and for safety reasons. So it took me that long to put in a milliliter. I'm going to put in just a little more. This patient mainly was placing fat for the texture, not for volume. She didn't have a big deficiency anyplace, which you'll see in the pictures I'll show you in a second. So, and I actually usually keep my thumb. The first part, I took it off for the video, but I usually keep my thumb, and that lets me know the level I'm at exactly. So I first usually place very superficially, and then I work my way down unless there's a big deficiency, and then I'll start with a 1 cannula and work my way up and switch to a 3 when I become more superficial. And I am using visual clues, but I'm also trying all the time to keep it really very smooth while I'm placing it by constantly changing position and fanning out. So that's the tear trough, and that's about 1.5 cc in the tear trough, which really is the medial eyelid. And here she is 5 days post-op, and here's the before and after. The 2 lower pictures are the after, and you can see a really nice change in the pigmentation and a really smooth take. And I think that the graded densities, I only use the highest density on her, the lower 1 cc, and I actually throw away a lot of the fat. If they're very skinny, then I might rebank it. But you can see a really even take. And look at her upper eyelids, how much the change in color. And her main reason for presenting was the change in color. But even in this young girl, if you look at the lower eyelid, and you see a significant change, not just in the color, but in the little wrinkling that was already starting to happen in the area, and the same in the upper eyelid, where I put 0.8. So, and the great thing about this is if it's done right, it's completely natural and completely undetectable. So the new consideration in medicine and surgery is regeneration, and it is the buzzword. And but also the future of fat grafting will be shaped by research. So make sure that if you're not doing research, that you're giving money to the people that are, to make our specialty, to give our specialty a chance to hold on to fat grafting and to improve our knowledge of what's going on. Thank you very much.